بسم الله الرحمن الرحيم. بشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. Welcome back, everyone. It's nice to be back with a full stomach from a sumptuous lunch, and I hope all had their share. I will try my best not to put you all to sleep this afternoon. For those of you who do not know me, my name is Nyer Firdoose. I'm not an endodontist unlike the previous two stalwarts. I'm an humble maxillofacial surgeon, and I will be picking up from where Dr. Nadeem concluded. The fun part is I get to salvage what the previous two speakers couldn't in terms of the tooth I mean. I will be speaking on surgical endodontics, and I want you all to remember this picture of the root apices. You will know why during my presentation. Okay then. The structure of my presentation will be a brief introduction with definition and history, followed by objectives and rationale for endodontic surgery, the factors influencing success or failures of surgery. Then comes the indications and contraindications, and I will be ending my presentation with a case description. Alright then, periapical surgery is part of endodontic surgery, and it is an option for post-endo treated lesions. Its aim is the treatment of periradicular disease, and removal of all irritants is the ultimate goal, as well as to obtain an airtight seal in the root canal, providing a hermetization and periapically with subsequent periodontal repair and regeneration of tissues. Surgical endodontics is defined as removal of tissues other than the contents of root canal to retain a tooth with pulpal or periapical involvement. Surgical intervention is required where endodontic treatment has failed. Have a look at this pictorial description, which is self-explanatory. The percentage of success of endodontic treatment has been consistently high, but failures may arise due to infection, poor access cavity preparation, inadequate instrumentation, obturation, and missed canals, or even coronal leakage. Periapical, that is periradicular surgery, includes a series of procedures performed to eliminate symptoms, which include periapical surgery, corrective surgery, intentional reimplantation, and root resection or removal of part of it or thereof. The periapical surgery includes the following two aspects. Number one, appropriate exposure of the root and the apical region at the apical region, and the second one is the exploration of the root surface for fractures or other pathological conditions. Surgical endodontics is not a recent innovation when we're talking about the history of the root surgeries. Definition and incision and drainage are being done since ancient times. As early as 11th century, the first case of endodontic surgery was performed by Albucasis. A root end resection, that is the episectomy, which is known as episectomy now, was first documented in 1871, and episectomy with retrograde cavity preparation and filling with amalgam was documented as early as 1890. The root amputation procedure was first introduced by Black and Inlich in 1886. Then it was dealt by Younger 1894 and Guerini in 1909. Then in 1930, the indications for endodontic surgery were proposed by a consensus. 1940 is the year when the triangular flap was first described by Fisher. Newman and Aiken described trapezoidal flap in the same year, and the semilunar incision was first described by Pash, hence it is also known as a Pash incision. The picture in this slide are of a semilunar flap on the bottom right corner, with the triangular flap design at the bottom left corner and a 4-point flap or the trapezoidal flap in the center of the slide. The objectives for surgery. The objective of periapical surgery is to surgically maintain a tooth that primarily has an endodontic lesion that cannot be resolved by conventional endodontic treatment or retreatment. How is it done? By effective curettage of pathologically affected periradicular tissues, which cannot be assessed in an orthograde approach. This includes therapy-resistant granuloma, true cyst, and foreign body reactions. Coming to the rationale for surgery, it is either resection or inspection of the periradicular tissues. Number one, the surgical resection of root apex is done in cases where the apical ramifications cannot be eliminated in a non-surgical endodontic treatment, or in cases of poor periodontal support. As you had seen in my first slide, there were a lot of ramifications in the apex alone. This cannot be eliminated in a non-surgical endodontic treatment sometimes. So it is important to surgically resect this root apex with multiple ramifications. Whereas the inspection of periradicular or periapical tissues is done to ascertain the causes of failure and trace the accessory canals in non-surgical endodontic cases that are clinically failing, as you can see in these two pictures. Now the main reasons for endodontic failure. This slide displays the electron microscopic images of the root apices. As we can appreciate in the first top picture, it is the presence of cementum lacunae on the root surfaces and the plaque-like microbes on the apical root surfaces and the dentine debris inadvertently extruded in the periapical region during instrumentation of the root canals. These are the three main microscopic reasons for failure of any endodontic procedure. There are certain factors which influence the success and failure in the periapical surgeries. Coming to the factors which are associated with the success, number one is a dense orthograde fill, which prevent the microbial leakage. On the bottom right corner, you can see a IOPA of two central incisors, which have been beautifully obturated in the root canal. And then because of this dense orthograde fill, there is minimal microbial leakage, thereby influencing or promoting its success. The second one being the healthy periodontal status. As you all know, we don't have to explain why the reason or the importance of healthy periodontium. Okay, and third one being in the clinical picture on top, no bony discontinuation or dehiscence. And adequate crown root ratio is also an important factor which influences the success of any periapical surgery. And finally, if the radiolucent defect is isolated to apical 1/3 of the tooth as seen in this IOPA, the radiolucency is affecting only the apical third of the distal root of this molar. These may affect the influence the success or the failure of the surgery. We saw factors associated with success. Now let's see the factors affecting the failures of the periapical surgery. Primarily, if there is any clinical or radiographic evidence of fracture, these slides here represent horizontal fractures in teeth and a single fracture at the level of the mid-third and the multiple fractures at the level of apex, below the alveolar crest and at the level of this EJ, as you can see in the bottom two radiographs IOPs. Now, the poor or lack of orthograde filling, as seen in these two radiographs, the top ones, and the radiographs, the first being underfilled and the latter is of an overextended GP cone well beyond the apex into the periradicular region. These are both a source of bacterial infiltration and contamination of the root canal procedure, leading to eventual failure. Marginal leakage associated with the failures of the periapical surgery or any restorations. Now, when we talk about the marginal leakage from ill-fitting crowns or post and or proximal restorations is also a contributing factor for the failures. This image is blown up picture representing the proximal surface of a tooth with a good marginal adaptation versus ill-fitting crown or restoration on the right side. Poor periodontal conditions preoperatively with or without tooth mobility is also a factor. Then comes the radiographic evidence of post-perforation, as you can see on this IOPA on the left, bottom left, and the inflammatory fistula that does not resolve or returns are all the reasons of failure in periapical surgery. When we say indications for periapical surgery, it suggests failure of non-surgical treatment. That is, the treatment should have been done at least twice. I'm sorry. When we say indications for periapical surgery, it suggests failure of non-surgical treatment. That is, the treatment should have been done at least twice. And they can be broadly categorized into, when we're talking about indications, these indications can be broadly categorized into the anatomic considerations, the restorative considerations, procedural errors, and large lesions in order to obtain a biopsy for the periapical region, and lesions that do not resolve with root canal treatment alone. Let's look at the individual categories of indications. First being the anatomic considerations, these prevent complete debridement or obturation. The reason being severe root curvature, as you can see in this image. It requires good clinical skills to navigate such intricate canals. Calcifications in the pulp or canal, as shown by Dr. Nadeem in his presentation, and obliterated or constricted canals, as we can appreciate in this radiograph. This image is self-explanatory, as in untreated or underfilled canals which lead to persistent infection. Another indication for periapical surgery is the need for surgical drainage via incision for purpose of evacuation of pus from periradicular or buccal tissues or from facial spaces, wherein the infection is odontogenic. And why is it done? This is done to prevent the infection from becoming worse or spreading in to the adjacent facial spaces, making the matters worse. The second category is restorative considerations. These compromise treatment. How do you say? How do you ask? Example is irretrievable endodontic post with apical pathosis. This image from left to right is of a precious metal cast post and core, followed by a titanium parapost. Then comes the titanium alloy parapost. This is a quartz fiber post, and the other one is the white fiber post, and the last one being the gold plated brass anchorage. In the dental literature, the reported failure rate of post-retained restorations is very variable. Whilst the review of the literature in 2003 by Goodacre et al. Found that the incidence of complication was about 10% over a mean observation period of 6 years. And an earlier review by Krugers et al. Reported a higher failure rate in the order of 22% over an average of 5 years follow-up. The most common reasons reported for failure of post-retained restorations were post-loosening, root fracture, caries, and of course that is secondary caries, and periodontal disease. The layer of thickness of a resin matrix cement depends on the fitting of the endodontic post to the tooth root canals, and any increase in the dimensions of the resin cement thickness causes the appearance of defects like pores, micro cracks, and micro gaps that can induce stress concentration and fractures at the interfaces of post and the roots, contributing to its failure. The restorative considerations such as overextended silver point fillings, apical perforations, extrusion of the root canal sealers into the adjacent structures, these are almost always iatrogenic. When we say iatrogenic, they are due to overzealous canal preparation and use of excessive force during obturation. This IOPA is of a mandibular molar distal root, and Dr. Nadeem showed an overextended GP cone in a maxillary first molar palatal root in one of his slides. And when we talk about such extrusions, when adjacent to vital structures such as maxillary sinus or neurovascular bundle, they may lead to debilitating effects in the day-to-day lifestyle of an individual. I don't know how many of you have seen calcium hydroxide or root canal sealers extruded into the nerve canals, as in the image on the right side bottom right side, but I have seen quite a few in my practice. Another indication for periapical surgery is as a corrective procedure in resorptive defects, which lead to perforations internally or externally, resulting in a communication between the pulp and the periodontium. Such cases, root resection is the way forward. Now, resorption occurs for several reasons, but most cases include sequelae to trauma. Few internal bleaching procedures are also known to cause resorptive defects in root. And of course, orthodontic tooth movement is known to cause orthodontic induced root resorptions, which Dr. Rahim would concur is due to excessive application of forces. Surgery is indicated in cases of planned hemisection or root amputation, and in some cases bicuspidation of a molar. These individual radiographs depict the hemisection, the root amputation, and the bicuspidation of a mandibular right first molar. When we talk about irretrievable material, these prevent canal treatment or retreatment, that is broken or separated instruments, or flushed restorative materials such as the calcium hydroxide or root canal sealers, and segments of post or foreign objects into the adjacent structures such as the maxillary sinus or into the nerve canals. The successful removal of fractured instruments may risk the long-term outcome of the tooth by sacrificing sound pericervical dentine, which may lead to perforations and predispose the tooth to vertical root fractures. The clinician should consider the microbiological and biomechanical aspects during clinical decision making of such cases. Coming to the procedural errors during treatment, such as broken instruments, ledging, gross overfills, and perforations. The endodontic failure still occurs despite technological advancements in the field of dental instrumentation and materials. The endodontic procedural errors are not the direct cause of treatment failure. Almost all procedural errors during endodontic therapy can be minimized or prevented and successfully treated, provided you have adequate skills and knowledge of what the procedure you are doing. The first image in the slide shows you a perforation of a palatal root. It can be either apical third or in the middle third or at the cervical or at the bifurcation level of the roots. Right? And the bottom right IOPA represents the persistence of infection, interface between the post and the cementum, and underfilled canals, right? And the top picture, it shows the transportation of the root canal, okay? And this the third image here, it shows the zipping, and the final image shows you the ledging. Large periapical lesions that do not resolve with the root canal treatment. It is of strong opinion that the pocket cysts may heal after root canal therapy, but the true cysts are less likely to be resolved by conventional root canal intervention alone, as per a study by Natkin, Oswald, and Kans in 1984. The periapical radiolucencies as described by Agassi, they present to 90 to 95% as inflammatory tooth-associated lesions, where the pathological makeup is periapical cyst, granuloma, and abscess. Here, to address the question of Dr. Shiraz about radiographic differentiation of granuloma, cyst, or abscess, according to White and Gauss's description in the textbook of radiology, they have categorized based on size. Anything less than 1 centimeter is abscess, 1.5 centimeter to 2 centimeter is a granuloma, and anything above 2 centimeter is a cyst. But to know exactly what type of cyst is inconclusive just by looking at a radiograph. So the conclusive evidence of type of cyst is almost always histopathological. In this slide, you can see the sagittal image of a mandibular anterior, where you can see a huge periapical radiolucency associated with the incisor. And the second one being the periapical radiograph, wherein GP tracing is being done from the buccal aspect. And the third one being of a central incisor with completely obliterated canal with a J-shaped radiolucency. This is suggestive of vertical root fracture. The final image on the right side shows a huge periapical radiolucency associated with the distal root of a first molar, and you can also see a file which has been wrongly perforated, and then it's out of the root and then it's still within the periapical tissues. In 2006, the European Society of Endodontology came up with updated indications, which are the radiological finding of apical periodontitis and or symptoms associated with an obturated canal. And the obstruction has to be proven not to be removable, and displacement of the obstruction did not seem to be feasible, or that there is a risk of the damage in terms of the periapical or pericementum or periradicular tissues. The second indication is the extruded material with clinical or radiological findings of apical periodontitis and symptoms continuing over a prolonged period. And there is persisting or emerging disease following root canal treatment when root canal treatment or retreatment is inappropriate. And the perforation of the root or the floor of the pulp chamber, and when it is impossible to treat from within the pulp cavity. These are the updated indications. We are done with the indications. Let's have a look at the contraindications for the periapical surgery. Mind you, these are just relative contraindications and not absolute. As in any surgery, a compromised medical status of the patient is a relative contraindication. The surgeon's skill and clinical expertise is a very critical factor for performing any kind of surgery. If an individual is not adequately trained or skilled, no matter what procedure one does, it is bound to be a failure. Vertically fractured teeth are under the ambit of non-restorable teeth, depending on the level and the extent of the fracture. And the unrestorable teeth are already deemed to be bent, so doing a surgery is pointless. Tooth with compromised periodontal support and non-functional teeth. Teeth with short roots, they compromise the stability and support for the tooth after surgery and may lead to mobility or avulsion after the periapical surgery. The contraindications of periapical surgery are also the factors which influence the failure of endodontics or endodontic procedures. The tooth root fractures with or without apical pathosis. This slide shows the different fracture types. The oblique comminuted fracture, and the clinical view of the full length of vertical fracture extending in the midline mesodistally, and the other two IOPAs show the extent of the fracture involvement from middle third to apex and a full separation of the segments from apex to the crown. According to the International Association of Dental Trauma guidelines, they have given a guidelines wherein they say the pulpal response should be evaluated after the trauma and up to 3 months later. Due to the non-reliable response of the vitality tests, endodontic treatment should be planned if after 3 months the electrometric or the thermal pulp testing is negative and or if radiolucency is detected. There are certain unidentified causes of root canal treatment failure, and the other contraindications are when conventional root canal is possible, you do not go ahead with the periapical surgery, and also when the retreatment of a treatment failure is possible, as in this IOPA, which shows there is a separated or a broken instrument within the canal. This can be easily bypassed with adequate skills and knowledge of the root canal anatomy and the morphology. So such cases, the periapical surgery is deemed contraindicated. Vital structures such as maxillary sinuses and neurovascular bundles may be prone to injury, leading to lifelong repercussions. A tooth with short roots have compromised bony support and are poor candidates for surgery. So root end resection in such cases may compromise stability. The first two IOPAs on the bottom left are of depicting the proximity of the metal foramen to the apices of the remnant first premolar, and just imagine if there was a second premolar there, the root apex would be lying just over the metal foramen region. And the mid X-ray, mid IOPA shows the proximity of the root surfaces of the first and second molar, maxillary first and second molar, the right side being in proximity or inside the maxillary sinus, and the short root anomaly on the right side, where there is severe discrepancy of the root length in comparison to the crown. There are the other contraindications are such as the structures interfering with access and visibility, for example, supernumerary teeth, odontomas, or exostosis. And finally, a medically compromised individual uh, with bleeding disorders are contraindicated for any periapical surgeries. Coming to the surgical procedure, and let me just take you through the different aspects of the surgical procedure. What we do before we start for the surgical procedure is some endodontists prefer to prescribe antibiotics as a prophylaxis, some do not. It's an individual preference. And followed by this, the second one is the preparation of the patient for anesthesia and the procedure itself with the well-informed signed consent. And then documentation of any surgical procedure is imperative to avoid getting into any medical legal hassles in the future or in the course of the treatment aspect. Now, once the patient is prepared and the anesthesia has been administered, the incision and the mucoperiosteal flap is done, and then to access the periapical regions and the mucoperiosteal reflection provides the adequate periapical exposure. Then we identify the periapical pathosis or the lesion, and then we do adequate and then adequate curettage, followed by root end resection. This is followed by root end preparation and the restoration retrograde direction. And then this is done by root end filling materials. And all along you have to do copious amount of irrigation over the tissues and the bone and the cavity to avoid drying up of the structures, which may lead to untoward events during the healing process. And finally, before you close, you have to do a radiographic verification of the retrograde filling and to check whether there is a complete hermetization of the root end uh, which has been resected. And finally, there is the flap is replaced and closed, and followed by post-op infections. And then you can call the patient after a week for suture removal and follow-up. The antibiotics, again, like I said, it's endodontist or the surgeon's preference, and preoperative prophylactic administration of antibiotics is indicated in cases of where there is the nature of the surgery and the potential spread of infection into the adjacent spaces. There is the risk of infection of the hematoma because the amount of edema expected after the procedure, and in cases of inadvertent opening of adjacent structures such as the maxillary sinus uh, during the molar surgeries. And the dosage of antibiotics, the first line of drug is penicillin, as in amoxicillin, or combination of amoxicillin and potassium clavulanate, that is augmentin, either 625 or 1 gram, 1 hour before surgery. If the penicillin patient is allergic to penicillin, clindamycin 600 milligrams 1 hour prior to surgery can be administered. The use of corticosteroids again is preoperatively at the surgeon's preference, because some literatures in some studies say that it reduces the edema and it improves or speeds recovery. The choice of anesthesia is again of the operator, and the most common the type of anesthesia or the choice of anesthesia is the lidocaine 2% with adrenaline. In cases of long-acting anesthesia or long-duration anesthesia, some people prefer Articaine, but Articaine comes with its own neurotoxic effects, wherein as in if you inject this Articaine close to any neurovascular bundle, there is some amount of neurotoxicity, and this may lead to inadvertent effects on the nerve, leading to negative effects of effects such as paresthesia or dysesthesia. The armamentarium of incision, as there are different scalpel blades. The number one is 11, 12, 12B, 15 and 15C. I personally do not like the last blade, which is the 15C, but there's a whole entire department which is in awe and love with this blade. I don't know for what reason. And for me, 15 and 12B are very good blades in terms of performing any periapical surgery. The 11 number blade is used for intracircular incisions or stab incisions in cases of draining any pus or abscess. And the blade number 12 is used for incising the interdental gingival tissues. And the difference between 12 and 12B is the internal angle is where the cutting edge is in 12, and 12B is both outer and the internal surfaces have the cutting edges. And the 15 number blade is used for vertical incisions and horizontal incisions or any type of incisions. Moving to the principles and guidelines for flap design, let me just make a point that I will not be going in detail about the designs of flap or the principles of flap or any other things to do with flap, because the description of flap alone takes the entire presentation. It takes I can stand here and then talk about the flaps alone for maybe 2 hours, so it will extend the presentation alone. So let's just stick to the principles of and guidelines of flap design in very concise manner. And then when we're talking about the principles and guidelines of flap design, we have to avoid horizontal incisions on the gingival ligament and supraperiosteal vessels, which are parallel to long axis of the teeth. And then you have to avoid placing an incision on the radicular eminences, as you can see in the clinical picture on the right side. These are all the elevated portions of the radicular eminences. Any incision over these will lead to the severing of the supraperiosteal vessels, and then may lead to excessive shrinkage or even formation of the scars. And we have to avoid vertical incisions placed over the intraradicular bone, and the incision should never be on thin bone and areas where there is a poor blood supply, which may lead to fenestration. Again, incisions should be placed and flaps repositions over solid bone. If placed over areas of periodontal bone loss or periradicular lesions, there is inadequate blood supply leading to necrosis and sloughing of the soft tissues. Hooley and Whitaker suggest that a minimum of 5 millimeters of bone should exist between the edges of the bony defect and the incision. And most importantly, you have to avoid incisions across any major muscle attachments. And when you're retracting the tissues with a tissue retractor, this tissue retractor should rest on solid bone and not on the muscles or the periradicular tissues themselves. This may lead to access which can be impaired or even trauma to the mucosal tissues, leading to delayed healing and untoward events. Continuing the principles and the guidelines of flap design, the extent of the horizontal incision should be adequate to provide visual and operative access with minimal soft tissue trauma. The junction of the horizontal, circular, and vertical incisions should either include or exclude the involved interdental papilla, and the flap should include the complete mucoperiosteum, as in a full thickness mucoperiosteal flap should be reflected. The various classifications are in circulation, but the main criteria for classification should be simple understanding of the salient differentiating features among the various entities, such as the anatomical position of the incision, the number of vertical entities in the flap, and the shape of the flap. In 2005, Kandaswamy and Gopikeshna, they came up with a newer classification of endodontic flaps. They categorize them into vertical, horizontal, and a combined flap based on the number of vertical entities. And the vertical flap is for incision and drainage, and the horizontal is again of two types, circular and mucoperiosteal incisions. And then the combined incisions, such as 2 vertical and 3 horizontal, or 2 vertical or 1 horizontal incision, or 1 vertical and 1 horizontal incisions. Now, when we talk about the horizontal incision alone, it is just a circular incision which creates an envelope flap. And if you give a mucogingival incision, it creates a semilunar flap. When we talk about the combined incisions, such as 1 vertical and 1 horizontal incision, it leads to a triangular flap. And if you incorporate 2 vertical and 1 horizontal incision, Again, it can either be a circular incision, which can be either trapezoidal or rectangular, or it can be a mucogingival, which is also known as Luke Oceanbean incision. Now, if you have a 2 vertical and 3 horizontal aspects, then it is a papilla-based flap. Establishing good surgical access requires considerable pre-surgical planning and involves numerous anatomic and physiological considerations. In this slide, I will show different flap designs in endodontic surgeries. The top left one is a semilunar flap, and followed by on the top right one is an annular flap. On the bottom right is the triangular flap with a circular incision and anterior vertical incision. And the final bottom left one image is of a trapezoidal flap, where you have a circular incision plus 2 vertical releasing incisions, both anterior, mesially and distally. The endodontic surgeon should understand the total concept of proper surgical access and develop a systematic approach to pre-surgical planning for each periradicular surgery case. Now, this slide shows you different, again, flap types, which is the top right one is a papilla preservation flap, wherein the entire papilla is excluded in the incision, in the horizontal incision, and the mucoperiocial flap is reflected. And the bottom right image is a submarginal flap, which is, you have 3 to 5 mm of gingiva, mucogingival tissues, which has been extruded in the horizontal incision, from the horizontal incision, and 2 vertical incisions are placed mesially and distally, and the mucoperiocial flap is reflected, and this is also known as Luke Oceanbean flap. And finally, on the top left image, this is a palatal flap, which is reflected by giving a circular incision and then reflecting the mucoperiocial flap in full thickness. The direction of the mucoperiocial reflection is very, very, very important in terms of preventing or keeping it minimally traumatic surgical procedure. After reflection of the gingival tissues, the elevation is continued in an apical direction, lifting the alveolar mucosa and the underlying periosteum from cortical bone to allow adequate surgical access to the periradicular tissues. A firm incision should be placed through periosteum to bone, and this slide shows you difference between the conventional armamentarium with the microsurgical armamentarium. After the incision, a full thickness flap is important to be reflected to prevent tearing and minimize bleeding, and the flap is raised with sharp elevators to sharp elevators with firm contact with bone, and enough tissue is raised to allow access and visibility to a apical region. The top left image of this shows you the difference between the conventional mucoperiosteal elevator reflector to the micro instruments, and then the top right image shows you the conventional mirrors with the microsurgical mirrors, and in the bottom right image shows you the tissue forceps which is conventional again, and microsurgical tissue forceps. And the final image in the bottom left shows you the conventional blade with the microsurgical blade. This is the microperiapical placement or map system, and the bottom left image is of the MTA carrier, which is also known as Dogan MTA carrier, and on the right is the image of the rosehead bars, and then the different pro-ultra surgical ultrasonic tips for routine preparation. This is again the different instruments, which shows the conventional scissors to microsurgical scissors and the conventional needle holders to microsurgical needle holders. And then the large image is of methylene blue. I will show you the reason as to why methylene blue is important. This is a case presentation, and the first image is of IOP of a lesion with extruded root canal sela in relation to tutu, and the incision was planned for submarginal incision, and the submarginal flap reflection was done with a full thickness flap, and this revealed the evidence of a periapical granuloma or cystic lesion associated with the apex of 2-2. And most of the granulomatous or inflamed tissue surrounding the apex should be thoroughly removed to gain access and visibility of the apex and to minimize bleeding. And then the bleeding, the hemostasis which was achieved by electrocautery, and a trough is created around the apex with a tapered fissure bar to expose and isolate the root end. The root end is then resected at different angles to create a bevel to allow proper root end restoration. The degree of the bevel can vary from 0 to 45 degrees, but most optimal is 15 to 30 degrees with 3 millimeter apex resection. Why do you ask that the root has to be resected 3 millimeters? This is due to the, if you can recall the first image of my slides of my presentation, there are apical ramifications. Most of the apical ramifications are confined to the 3 millimeters of the root apex. Hence, you have to eliminate all these in order to have a successful procedure. And the reason why we do not recommend the root resection at 45 degrees is there is exposure of multiple dentinal tubules leading to microbial leakage, and therefore affect the healing process and may lead to failure. So the optimal is stick to 15 or 20 degrees, or even 0 degree is better. But if you give a 0 degree resection, you might land up into difficulty in the access or the visibility of the root end while its preparation. Once the root end is resected, then it's followed by the application of the methylene blue solution to the root tip, and this exposes the again a presence or absence of any fractures, which may allow it to for a better access, visualization and inspection of the root end. And a thorough debridement of the granuloma or the lesion is done, as you can see in this clinical picture. And the inspection of the resected root for presence or absence of any accessory canals or fractures with the application of the methylene. Finally, the root end preparation using ultra pro surgical ultrasonic tip driven by ultrasonic scaler is done. This is the reflection in a micro mirror of the prepared ultrasonic root end preparation, and this is done followed by the application of the root end filling materials such as the MTA or biodentine, and this MTA is a flow material and is directly dispensed into the root end preparation, and excess is removed to the level of the resected root. You don't underfill it, you don't overfill it, you just fill it at the level of the resected root. And then followed by this, you have to take an immediate post root end preparation post and root end restoration radiograph to verify whether you have a hermetic seal or the extent of the root end preparation filling. In conclusion, I would like to say many factors influence performing periapical surgery, and they should be taken into account to achieve predictable success. All indications and contraindications should be well known, since non-surgical treatment is not always possible or advisable. The differential diagnosis of periapical lesions should be well known, since not all are of endodontic origin, and proximity to important anatomical areas requires careful preoperative planning and intraoperative state of awareness. The preservation of the natural teeth should be our goal, since they still cannot be equally replaced by existing artificial materials and technologies. So the preservation is our penultimate goal. Thank you. The floor is open for questions now, and I would suggest if you have any endodontic related questions, please direct them to Dr. Nadeem and Dr. Shiraz, as they would be in a much better situation to elaborate on it. Any surgical questions? I'm open, and then let's start the question answers. Thank you again. And before we end the presentation, I would like to thank Mr. Sonil and his team for organizing such a beautiful event, and then giving an opportunity for all three of us to speak and then impart a knowledge. Thank you again.